Hello everyone, welcome back to Learn Anesthesia Basics. Today we will be discussing about interscalene block. Let's learn systematically about the interscalene block. So, which part of the brachial plexus is blocked in the interscalene blocks? The roots of the brachial plexus are blocked in this interscalene approach. So, for what type of surgeries do we use this block? We use this for shoulder surgeries, clavicle, and up to mid-humerus level. These are the surgeries for which we can use this interscalene approach. If we are blocking the roots of the brachial plexus, why not for other surgeries of the upper limb? Because ulnar nerve is paired, in this approach. So sensory and motor functions of the fourth and fifth digits remain intact. So we can't use it for the other surgeries below the mid-humerus level. How do we select the patient? Nearly all patients are applicable for this approach. Even obese patients can also be given this interscalene block because the scalene muscles and the vertebral body anatomy will be identifiable even in obese patients. However, it should be avoided in patients with impaired pulmonary function because the phrenic nerve is blocked almost always in this approach. Now, what about the choice of drugs? Choice of drugs and concentration of drugs is based on the different surgeries and the different duration of the surgeries. For example, if there is less complex and OPD procedures or OPD surgeries or daycare surgeries, we can use 2% lidocaine or 1.5% mepivacaine. This gives surgical anesthesia of 2 to 3 hours if it is given plain, and with additives like epinephrine, it gives surgical anesthesia of up to 3 to 5 hours. For more extensive surgeries or long duration surgeries, we use bupivacaine 0.5% or ropin 0.75%. If they are given plain, they give surgical anesthesia of up to 4 to 6 hours, and with additives, they give surgical anesthesia up to 8 to 12 hours. If we are giving for postoperative analgesia, then lower concentration of drugs are sufficient, like 0.2% of ropivacaine. And how much ml of drugs are we supposed to take? For this approach, 10 to 30 ml of local anesthetic can be given. What about the position of the patient? Now that our drugs are ready, we have to position the patient. How do we position the patient? Positioning of the patient can be supine, beach chair, or semi-lateral decubitus position. Any position for the comfortable placement of ultrasound transducer and needle advancement is appropriate for this approach. In this position, the patient is positioned at an angle of 45 degrees, head up, and there is a pillow under the head, and head is turned towards the opposite direction. And a pillow or folded blanket can be placed under the ipsilateral shoulder to create more room for the needle to be advanced from the posterior side. The ultrasound should be placed on the opposite side to the block given. Now that we have positioned the patient, let's see the surface anatomy of importance for us. The most important surface landmarks for us for this block are the larynx, the sternocleidomastoid muscle, and the external jugular vein. So, let's see in this image. Here is the thyroid cartilage, the cricoid cartilage, sternocleidomastoid muscle, the anterior scalene muscle, and the middle scalene muscle. And in between the two scalene muscles is the interscalene groove. So, technically, we perform this block at the level of C6 vertebral body, which corresponds to cricoid cartilage. So, if you project a line lateral to the cricoid cartilage, we are at C6 level. So, one should be able to roll off the fingers of sternocleidomastoid muscle and onto the belly of anterior scalene muscle and then into the interscalene groove. When firm pressure is applied, in most individuals, it is possible to feel the transverse process of C6 vertebra. The external jugular vein overlies the interscalene groove at the level of C6, but this should not be relied upon. And the anterior scalene muscle and the interscalene groove are oriented at an oblique angle to the sternocleidomastoid muscle. And we can see that the phrenic nerve is present on the ventral surface of the anterior scalene muscle. Now, when we want to give this block through landmark technique, we identify the interscalene groove and we palpate the interscalene groove with our two fingers and place the needle in the interscalene groove in the direction of caudal and posterior direction. We ask the patient if they can perceive any paresthesias, and once the patient complains of paresthesias, we give the drug over there. If the paresthesias are not elicited immediately, we walk through the needle in the same direction of insertion. Now that we have established the landmark technique, let's see the ultrasound guided nerve block. For ultrasound guided nerve block, we need to know the probe position, the patient position, and what do we see with the different probe positions. So let's see the different probe positions and what do we see in the ultrasound. It's easier to identify the brachial plexus at the supraclavicular region because of the nearby close proximity of the plexus to the pulsating artery, that is subclavian artery. So we place the probe at the supraclavicular region just behind the midpoint of the clavicle. There we have to position the probe so that as if we are scanning the thorax region, and we can see the pleura, the shadow of the first strip, and above that we can see the pulsating subclavian artery. Lateral to the subclavian artery we can see plexus as bunch of grapes, and we can also see the anterior and middle scalene muscles. We have to trace the probe in the upward direction so that we lose the artery and we can clearly identify the anterior and middle scalene muscles with the plexus dividing. As we move the probe towards the C6 level, we can see the anterior scalene, the middle scalene muscles with the plexus. These are the C6, C5, C6 and C7 plexus. And these can be identified as the traffic signal sign or the three dots which can be seen in ultrasound image. As we move up, we can see the anterior scalene and middle scalene muscles and the hypoechoic plexus along with the external and internal carotid artery and internal jugular vein. Once we identify these plexus, fix the probe at this position and take the needle and enter the needle from the lateral and posterior direction towards the anterior and medial direction. Aim the needle so that we insert the needle between C5 and C6 plexus or above C5 plexus. Once the needle position is confirmed above the C5 or between C5 and C6, inject the local anesthetic so that we can see the spread of local anesthetic between the plexus. Make sure we are not puncturing the hypoechoic area in between. The ideal spread of local anesthetics from a single injection is anywhere next to the brachial plexus, and the needle can be redirected if the spread around the plexus is not adequate. And alternative technique is to go out of plane and inject the drug. If we plan to place catheters, we can use larger gauge needles and secure the catheter after placement. The catheter can be placed by in-plane or out-of-plane technique. And once the tip of the needle is above C5 or below the both fascicles of C6, the catheter can be threaded inside and fixed with surgical glue and well-placed dressings to prevent the catheter slip. That's it for today. If you want any other topics, please do comment below. Thank you for watching. Please like, share and subscribe.